academic session with Dr. Nipun, Dr. Nipun, and Dr. Anuj for the academic session. So Dr. Anuj will be presenting an academic presentation on vein occlusion, that when a patient comes in OPD with a vein occlusion, so how to approach the patient, how to manage the patient, and what are the types of vein occlusion, the radiology and management. Over to Dr. Anuj. Thank you.
Today we will be discussing about retinal vein occlusion. In this topic we will be covering introduction, classification, clinical presentation, management and treatment, and how to approach to the patient. First, the introduction. Retinal vein occlusion is described as obstruction to retinal venous outflow leading to increased venous pressure and secondary retinal changes. So, why retinal vein occlusion matters to us? So, because it has a wide global impact and it is considered to be second most common retinal vascular disease. Coming to the epidemiology, it is considered to be 5 times more common. BRVO is considered to be 5 times more common than CRVO. Males are affected more than the females, and most of the patients present with unilateral disease, and only about 5 to 10% patients present. Coming to the risk factors, being hypertension is the most common risk factor. Second is the heart attack, then other risk factors are high cholesterol, diabetes mellitus, history of stroke. Then ocular risk factors are glaucoma. So how does glaucoma affect? It increases the intraocular pressure which compresses the center retinal vein at lamina propria. Other risk factors are ocular hypertension, optic disc occlusion. How does optic disc occlusion affect? It causes the mechanical compression. And what are the other systemic factors such as hypercoagulable state, vasculitis, antiphospholipid syndrome. Coming to the classification in pathophysiology, it is classified into two: central retinal vein occlusion and branch retinal vein occlusion. Central retinal vein occlusion is further classified into ischemic and non-ischemic. Branch retinal vein occlusion is classified into two: major BRVO and minor BRVO. In central retinal vein occlusion, the site of occlusion is at or near the lamina propria of the optic nerve. If we see the non-ischemic CRVO, in fundus there is presence of few hemorrhages. In ischemic CRVO, the vision is usually dropped to less than 6/60, and RVD is usually present, and the fundus picture is appear to be tomato splash or blood in center.
So till now Dr. Anuj has mentioned about regarding the radiology and the types of vein occlusion. So Dr. Anuj said that vein occlusion is the second most vascular cause of vascular retinopathy cause. So which is the first cause? Diabetes. Yeah, diabetes is the first cause. So now in Dr. Anuj has mentioned in young patients and in adult patients. So I want to ask Dr. Anuj that if a patient comes with a vein occlusion and his BP, blood sugars and lipid profile are all normal, so what next investigations would you like to do in the same?
So for young patients, we are going to check for homocysteine levels. Then yes, homocysteine levels. then they can also be inherited problems like factor V late mutations, then 14C and 14S deficiency, then anti-thrombin deficiency, then APLA syndrome is also there. These are the inherited ones. Then acquired can be other causes like sarcoidosis, Behçet syndrome, Waldenstrom's macroglobulinemia, then multiple myeloma is also one of the causes. Then also, sir, in hot countries, severe dehydration can also be a cause in case of young patients.
Very nicely elaborated, Dr. Anshika. So as you mentioned, it's in young patients, so anemia is an important cause. So CBC, complete blood count, even with peripheral smear, it is important to rule out leukemia. And all the blood dysplasias like coagulopathies, like protein C, protein S, factor V latent deficiency, and serum homocysteine. Serum homocysteine is said to be that hyperhomocystinemia. It is said to be an independent risk factor for vein occlusion in young and also artery occlusions also. In hyperhomocystinemia also known to cause arterial occlusion. And in the younger patients, you will have thicker blood columns as compared to in adult people. You will have thicker blood columns, and in anemia and in infective endocarditis, there will have broad spots also. And we have seen one bilateral vein occlusion in young patients. We did a peripheral smear, and it turned out to be leukemic retinopathy. The patient had ALL, acute lymphocytic leukemia, with the leukemia he had. And these are the causes of vein occlusion. And as I mentioned, that even ASO titer and the inflammatory causes, the post-uveitis causes, Behçet's disease, this sarcoidosis, toxoplasmosis, all these can cause vein occlusion in young patients. So in young patients, these are the investigations besides the first line of investigation which can predispose to vein occlusion. So Dr. Anuj, we will be discussing about non-ischemic and ischemic CRVO. So how is the classification with, like, what are the differences between non-ischemic and ischemic CRVO? And there is one more entity which can get confused with non-ischemic CRVO or ischemic CRVO, that is called ocular ischemic syndrome. So, like, can you differentiate between the three, between non-ischemic, ischemic, starting when the patient presents?
Basically, in non-ischemic, the patient will be better than 6/60, and ischemic patient will be less than 6/60. There will be presence of RAPD in ischemic CRVO, and RAPD may or may not be present in non-ischemic CRVO. Fundus picture would be, there will be few hemorrhages in non-ischemic, and ischemic would show the presence of disc edema along with hemorrhages in all four quadrants along with cotton wool spots. If we see the investigation on ERG, the non-ischemic part would show near to normal ERG, and in ischemic CRVO, the amplitude of ERG would be reduced. Macular edema would be mild in case of non-ischemic CRVO, and in case of ischemic CRVO, it would be severe. And one more thing, neovascularization, neovascular glaucoma is rare in case of non-ischemic CRVO, and in ischemic CRVO, vascular glaucoma is common to occur.
Nicely elaborated. So when a patient comes in OPD with a diminution of vision, painless diminution of vision, so and we check for a pupil reaction. So RAPD, no RAPD. Ischemic RAPD, CRV non-ischemic, there will be no RAPD. If vision is good, then it falls in something called can be a non-ischemic CRV. And see the anterior chamber cells also. Low-grade cells are this thing in ocular ischemic syndrome. How do we differentiate between ocular? Sometimes clinically it is very difficult to differentiate between ocular ischemic syndrome or CRVO. So what you see is a low-grade cells and a history of stroke or any cardiac event can predispose to ocular ischemic syndrome. Okay, and ischemic CRVO also look at very carefully at the iris borders. In the undilated people, the iris border, if it shows any signs of neovascularization, prognosis iris, so you see that. So basically, non-ischemic was classified on the basis of fundus fluorescein angiography. So what they measured is the capillary non-perfusion areas. So the less than 10 diameter of the capillary non-perfusion area was classified as non-ischemic, and greater than 10 degrees of ischemic was classified as ischemic CRVO. So yeah, these are the points. Thank you. Go ahead.
Now the pathophysiology. Venous thrombosis, vessel wall changes, along with hypercoagulability. These are the three factors which are mainly responsible for retinal vein occlusion. These three are considered to be a virtuous triad. Venous thrombosis leads to increased venous pressure, which leads to vascular leakage and macular edema, leading to ischemia and vascular endothelial growth factor upregulation. Clinical presentation. Symptoms of retinal vein occlusion. Patient usually presents with sudden painless visual loss, typically over hours. Patient may prescribe the vision loss as curtain or shadow. The key issue which we have to ask to the patient is about the duration and progression, how does it progress, and whether there was a prior episode or not, and underlying status. Then we have to ask about the systemic history of hypertension, diabetes, any history of glaucoma or any drug history.
Which drug is important, particularly in females?
More factors. Then we have to examine the patient. First is visual acuity, which is considered to be the baseline. Then pupils for RFID, intraocular pressure, which is usually elevated in neovascular glaucoma. Slit lamp examination to see for neovascularization of iris and angle. Then we have to see the fundus for fundus changes. This is a fundus picture of CRVO. There is presence of hemorrhages in all of the four quadrants of fundus, along with presence of cotton spots. We can see that there is presence of optic disc swelling. This picture is known as blood and hinder or tomato splash fundus. This is the fundus picture of BRVO. We can see there is a wedge-shaped, flame-shaped hemorrhages in the supratemporal quadrant. Why does supratemporal quadrant is affected more in BRVO? It is because there are more AV crossing points at that area. Now the OCT findings would be there may be presence of cystoid macular edema, which appears as honeycomb pattern with hyperreflective intraretinal cyst. There may be presence of subretinal fluid. Subretinal fluid is accumulation of fluid between photoreceptors and RP layer. There may be disorganization of retinal inner layers, which is a strong predictor of irreversible visual damage when present over 6 months. If we measure the central retinal thickness, if it is more than 300 micrometer, it indicates of active disease.
Bridging retinal processes are present, so it will be a good bad prognostic biomarker.
So the kind of process is the good prognosis.
Good prognosis, because the connections are there between the outer and the inner retina. So in trail, this also creates a poor prognosis. Okay. So in trail, the dense implant is said to ameliorate the trail. The subretinal fluid and the cystoid macular edema, these are a better poor prognosis. We have to see the residual tissue between the outer and the inner retina, as we discussed in diabetic macular edema. And if there is a giant cyst is there, so as we discussed, the giant cyst compresses the photoreceptor. So it is a bad poor prognosis. Okay. And what are the other prognosis? What are the about the ELM, EZ line, and ISOS, if it is continuous?
The disruption of ISOS junction is also a bad prognostic marker in OCT.
And sometimes you see a presence of foveal bulge in cases of retinal vein occlusion. Is it a good prognosis or a bad?
Foveal bulge.
Yeah. Right about that? Foveal good. Good. It's a good prognosis. Foveal bulge is good. Yeah. Okay. So these are the prognostic and hyperreflective foci. Same as in diabetics we do. In chronic CRVO and chronic uvea, if there is a hyperreflective foci and a drill, then we tend to shift towards the extravitreal implant, steroid implant, and this thing. After the injection, we generally tend to, if they are not responding to anti-VEGF, we tend to shift it in the further steroid. Yeah, these are the, in a nutshell about the OCT biomarker.
Now, other investigation is FFA. FFA would show delayed filling in venous phase, and retinal veins would appear dilated. Why do we do FFA? To look for macular ischemia and to evaluate the extent of capillary non-perfusion, and also to differentiate between neovascularization and with collaterals. Additional imaging would be, which we would do, would be OCT angiography and ERG. Coming to the systemic evaluation, all patients would be requiring blood pressure measurement, fasting blood sugar, lipid profile, CBC, serum creat, and some selected patients like with age less than 50 years, young patient, bilateral retinal vein occlusion, recurrent RVO, or there is a family history of thrombosis. Then we would be going for other investigation like protein C, protein S, antithrombin 3, factor V, and A plus antibodies, serum homocysteine. Coming to the management, what should be the goal of our management? The first is maintenance and improvement of visual acuity. Second is reducing the macular thickness using anti-VEGF therapy, and third is prevention of complications. So the first line treatment would be anti-VEGF therapy. So mechanism of action is it binds to the vascular endothelial growth factor and inhibits the vascular permeability and reducing the macular edema. There are three main drugs which are used: aflibercept, ranibizumab, and bevacizumab. Various studies have been done on these three drugs. Ranibizumab 0.5 milligram monthly injection is given, and In initial phase, 3 monthly loading was 3 months. Every month. If patient is non-responsive to anti-VEGF therapy, we shift to corticosteroid, ozotide, which is considered to be second line therapy. There is a Geneva trial which has shown significant improvement in visual acuity using dexamethasone implant.
In one study they have compared this 1 mg and 4 mg triamcinolone also. So for the macular edema, so 1 mg triamcinolone, they required lesser number of patients require IOP lowering medication as compared to the 4 mg triamcinolone. So Dr. Anuj, like any studies, like when did you go for a laser PR, pan-retinal photocoagulation or a sectoral PRP? So it was a fresh in which we injected it was a fresh supratemporal retinal vein occlusion, macular edema. So would you go for a PRP in that case, or when would you go for a PRP as per BRVO? DBOS and CBOS studies.
If there is absence of macular edema and only there is presence of neovascularization, then we would consider to go for PRP therapy.
No, even in case of macular edema, you can give an anti-VEGF first. If there is the most important point in pan-retinal photocoagulation is if there is any presence of neovascularization. So in case of BRVO, more predisposes to NVE, neovascularization elsewhere. So you can go for a sectoral PRP. And in cases of CRVO, where there is an NVI, or then you can go for a sectoral PRP. Many of the times we see cases of branch retinal vein occlusion with vitreous syndrome. We don't see an NV, but we see a vitreous syndrome. And then we do an epical of vitreous image is leaking from bleeding from the neovascularization elsewhere. So we need to do that sector PRP in case of BRVO or HRVO, retinal vein occlusion. So basic point is whenever you see the neovascularization picture, you go for a PRP. And for neovascular glaucoma, PRP is very crucial. PRP and one investigation you require whether to inject anti-VEGF in neovascularization or not when OPD is given. What's the so you want to see the angles. Okay, so one is required to see the angles, to see the neovascularization of angles also, and if it's an axial closure or it's like any sitting is there, closure is there, or it's an open angle. Okay. Yeah. Go ahead.
Then what the surgical option is laser photocoagulation. PRP we have already discussed. Second is grid laser photocoagulation. Grid laser is done for the treatment of
Grid laser is obsolete.
surgical options we have is past and vitrectomy, which is done in cases of non-clearing vitreous hemorrhage, presence of fractional retinal detachment, or there is a combined fractional rheumatogenic detachment. Then how we approach to the patient? First is urgent eye examination, then imaging studies like OCT, FFA, fundus photography, then systemic workup. And we have to start the initial treatment within 2 to 4 weeks. And the last is about the counseling and coordination. Follow-up protocol. In active treatment phase, the patient is advised to visit monthly. At each visit, we have to measure the visual acuity, OCT, IOP, and slit lamp examination along with dilated fundus examination. In maintenance phase, the frequency of examination is every 6 to 12 weeks. And at long-term monitoring, we have to watch for recurrence of macular edema, whether neovascularization has reappeared or not. And we have to also examine the fellow eye. Prognosis in about 60% of patients gain more than 15 letters with anti-VEGF therapy. and 70% of non-ischemic CRVO have better prognosis. Thank you.
Very nice presentation, Dr. Anuj. So, in a nutshell, so as we see, eye is a window of the diseases which is occurring inside the body. So, if any vein occlusion is there, so first of all, we measure the blood pressure. So, suppose if a young patient comes and with a vein occlusion and his BP is high, so we can, look for the patient as a whole, not only the eye. So, we can advise him to undergo his cardiac workup, his kidney workup. Sometimes we have patients who had undergone USG, doctor kidney and come out to be few chromocytoma. So cardiac workup, kidney workup, so young patients with high blood pressure and high lipid profile, so they require the full body checkup also. And recently we had a young patient, very young, like around 16-year-old boy who had anemia and hyperhomocystinemia. So we did not expect that seeing the patient, the field of the patient, but he had anemia and hyperhomocystinemia and he had a vein occlusion near the optic disc. So that's why it is very important for a systemic approach. So see the drug says see the patient as a whole. What is the risk factor causing the vein occlusion? With the help of anti-VEGF and BRVO, we are regressing the new vessels. We are regressing the macular edema. But what is the source of the vein occlusion? It is very important to find out what is the etiology of the vein occlusion. Very important to find out. Any questions? Combat questions to Dr. Anuj? Any questions? Yes. Any testing case or any dilemma you had? We have time. So I want to ask Dr. Anuj one question that if we suppose we gave a ranibizumab to one patient with vein occlusion and he does his vision improved from 636 to 612. Then again we injected ranibizumab, but the vision did not improve much. And after 3 months he is lost to follow-up, and after 3 months he comes with a hyperreflective foci and disorganization of inner retinal layers with a deranged lipid profile, and we check for lipid profile control, deranged blood pressure control, and all like the metabolic parameters are in control. And now he is a sort of a chronic vein occlusion. So now what will be your management options then? Yeah.
We can shift the patient on steroid injections, and we will look for any neovascularization. If neovascularization is present, we will go for BRVO therapy. And
yes, as I pointed out, so my preferred choice would be dexamethasone implant and or a steroid injection. As Dr. Anuj said, dexamethasone implant is FDA approved, and off-label we can use intravitreal triamcinolone also, that 1 mg, 2 mg and 4 mg. Suppose there is a vitrectomized patient. So Dr. Nishan said that a vitrectomy has been done for retinal detachment or vitrectomies and the oil removal has been done. Suppose this BP raises and there is a vein occlusion with macular edema and like it is a chronic macular edema. So which drug would you prefer then? In a vitrectomized case, the VC is compromised actually.
So they will avoid the steroids, triamcinolone they will avoid, because it can come to the NPH if there is a PCR. We can shift to only anti-VEGF.
Anti-VEGF we can shift to it. Anti-VEGF, the vitreous is the carrier. So anti-VEGF will work for only for like the shorter duration. So we can go for this thing, posterior subtenium triamcinolone. So it has a better, but we have to monitor the intraocular pressure. And this new vascular glaucoma cases, the 90-day glaucoma we call post-CRVO, is very difficult to manage. They are very complicated cases to manage. So, like no matter how many anti-glaucoma drops we give, how many Dimox and how many acetazolamide we give, sometimes it is very refractory. So sometimes they have to go for the glaucoma surgery. So the first we need to do the retina management, and that the PRP as an extent possible. I am saying to the extent as possible because you will see that the neovascular glaucoma patient, they have pupil dilatation is very less. Recently we saw the patient with pupil dilatation is very less. So we have to give anti-VEGF and PRP as to the extent as possible. So what is the difference between PRP? Dr. Nipun, can you tell us what is the difference between the PRP in diabetic retinopathy and in vein occlusion, CRVO? In both the cases we are doing PRP. So I mean to say the difference lies in one point. So can you, I will just giving you the hint that suppose I did a PRP, one patient of vein occlusion and one patient of diabetic retinopathy, PDR patient. So I did full 2-3 settings, complete PRP I have done. In diabetic patients, I went like there is the Kota, I went till mid periphery vesting, and in vein occlusion same I did. So in which patient I need to augment more? In vein occlusion or a PRP? So it is my PRP complete in that patient of vein occlusion. I didn't go till the Kota, I went till the mid periphery. Or just to the mid periphery. Any points?
Complication is more required than after.
So what they say is that in diabetes also the recent studies has shown that ultra wide field angiography that in periphery also there is a new vascularization. So we should go towards the periphery. But in vein occlusion, these capillary non-perfusion areas are there more in the periphery. So what the studies say that we go more towards the aura as compared to the PRP in diabetic retinopathy. Okay, and the differentiating factor in ocular ischemic syndrome is that history of any stroke or cardiac event, and there are low grade cells like 1+ cells in the anterior chamber, and we see the capillary non-perfusion areas, and we can do a prophylactic PRP. Although the study says that whenever there is a vascularization, then only you have to do PRP, but if the patient is far off, can be like if there is a loss to follow-up, we can do a prophylactic PRP to prevent the further neovascularization and the complications. Yeah, so thank you. That's a nice presentation. Any questions? Okay, thank you.